in this segment, the first question I'm going to ask, and we've got a mix of emergency physicians, primary care, hospitalists, a nice mix of providers. If you have to pick the top 2 or 3 clinical situations or applications where you use focus cardiac ultrasound in your practice as non-cardiologists, why don't we start off with Claire, because you're topmost on my Zoom window, and we'll kind of work our way down the list.
Thanks. Hey, Mike. It's Claire. I'm up here in Canada. I'm a POCUS educator in the University of Toronto and a POCUS enthusiast at Toronto General Hospital. I use POCUS for top 3 focused cardiac ultrasound applications. Chest pain, I've picked up a few MIs, and once in a while patients just appreciate knowing in advance if that's what's going on. Shock, I want to know if the pump is bad or the tank is empty. And the third thing is shortness of breath, because I want to know if the heart is part of the problem. That's my 3.
Awesome. Rachel?
Hey, I'm Rachel Liu. I'm the Director of Point-of-Care Ultrasound Education for Yale School of Medicine. If I had to focus solely on heart and make it diagnosis-based and not complaint-based, I would say echo for depressed EF, PE, ACS, so MI, focal wall motion abnormalities, and I will add dissection. We see a lot of dissections, and unfortunately, a lot of them are headed to cath lab before that dissection diagnosis is made. So for us, we actually echo almost everyone who is going to our chest pain observation unit. And of course, cardiac arrest.
I think cardiac arrest may end up being the least controversial. We'll try and see if we can find something we disagree about utility for echo and cardiac arrest. Gordy.
Yeah, I'm Gordon Johnson. I'm a hospitalist here in Portland, Oregon, and do a lot with global health as well. So I think my biggest use is definitely ruling out tamponade. I think I always talk about your first kiss when I'm educating POCUS people. And when you first started and you find a patient that was billed to you as CHF, like Dr. Stone calls you from the ER and says, I got a CHF patient. And then you look and you see cardiac tamponade. That's really the time that you say, okay, that I definitely need to learn how to formally do this. And it also confirms my suspicion. Oftentimes I think they have heart failure. I do POCUS and I rule it in and rule out other means. And then I think the third thing for us as hospitalists is really following the patient through the hospitalization and watching their volume status day to day. So when I discharge them, I'm very confident that I've got them euvolemic. I've seen the IVC go down clinically, listen to their complaints as well, BNP, all these things are another piece of information, but POCUS is definitely a key one.
Thanks, Gordon. So Gordy and I work in the same hospital, so I probably have admitted patients to him that I thought were CHF, but actually had tamponade. Hopefully not. But
no, I don't think
anything's possible. Anything's possible. I think that concept of the first kiss with POCUS. My first kiss with POCUS was also cardiac based, but I remember very well a young man in my residency who came in short of breath, history of asthma, wheezing, getting standard treatment with beta agonists and steroids and a little bit of fluids because, why not? He's in the emergency department, who just started to get worse instead of better. And I remember looking and finding this guy's dilated cardiomyopathy due to undiagnosed myocarditis. So again, complete sort of U-turn in your treatment, and it's amazing how you can get these impactful decisions. Steve.
I'm a family doctor with an active practice in a small town in Port Townsend, Washington. And I think, my world is prevention and managing stable chronic illnesses. So I kind of came into POCUS looking at the history of, stories of ER doctors who just using their wits and an ultrasound made a quick diagnosis and saved somebody's life. But that doesn't happen to me that much. Once in a while, I come across somebody who had a silent end STEMI, and it's the new onset heart failure that makes the diagnosis way more quickly than if I just send them off for a broad array of tests. Another thing that's really powerful for me for POCUS is, I practice in an office where we don't have every test available like you do in the hospital. If I want a chest x-ray and a BNP and some of that, they've got to go get that done and come back and see me for a follow-up visit in a week. So there's just a ton of information that I can get just through looking at lungs and IVC and getting a quick ejection fraction. And then I'm really excited about kind of using this to sort of manage my CHF patients. I've had a few that, gosh, if they get too dry, they get dizzy and a little bit short of breath. And if they get fluid overloaded, they get short of breath and maybe a little dizzy. And then how do we manage this? And as soon as I started just looking at their lung fields and their IVC each time they came in, suddenly this person isn't bouncing in and out of the ER every month. So, you know, if I'm able to do my job, they never have to darken the doorstep of you ER docs or intensivists. So it sure helps me do that.
That's fantastic. I mean, I was guessing in advance of this conversation how long it would take us to steer from focused cardiac ultrasound alone into a more holistic volume status, vena cava, lung ultrasound, and it's not surprising, right? I think that you know, being more you know, generalists as opposed to you know, our cardiology colleagues, we're used to looking at multiple different parts of the body and things that would traditionally be in the sphere of radiology, say, you know, assessment of the lung, whether it's with, well, if it's with radiology, probably chest x-ray, but you know, a radiology assessment and a cardiology assessment in the traditional, you know, medical sense is something that POCUS just kind of knocks those barriers down. And all of a sudden, if you want to look at the lungs, the heart, the lower extremities for a DVT, you know, the really everything's open to you. You don't have to, you're not ordering separate tests from separate departments, and you're able to kind of incorporate all of that. Gordy, I see you got your hand up.
Yeah, I just want to put in one point. I think that the stethoscope is really complementary, and I also think POCUS is very complementary to the physical exam and teaching it. And I say that I have markedly improved my physical exam after adopting POCUS, because you can confirm what you were suspicious of. I hear bronchial breath sounds, I see the consolidation. If someone's obese, I can look at their JVD, I can confirm it when I'm showing medical students where the meniscus is. So I feel strongly about that, and it's extremely satisfying to do that, to make it a part of your teaching on physical exam rounds.
You know what? I completely agree. So yes, I'm a very big POCUS enthusiast, but I'm also a physical exam teacher. And I have been ever since I was teaching faculty, because you're right, I don't think we get enough physical exam teaching in med school, especially in North American med school. And I trained in the UK system. So I really much value that POCUS can help clear up some things where physical exam is not able to pick up, but they are two distinct entities that should be taught separately.
Well, and there's that back and forth, you know, in the same way when you're learning POCUS and you do a study and then you get some sort of confirmatory study, a CT scan, let's say, or a comprehensive ultrasound, that informs your POCUS confidence and your ability to say, hey, I think I saw this. Was this present? Was it not? Did I get it right? Was there something about it that I missed? I think that same back and forth happens with the physical exam, where, you know, I still, even though I don't have a stethoscope, I chalk it up to my bad ears. You know, when I go and look at someone's leg, I have a pretest sense of, is this a DVT? Is this cellulitis? Is this a Baker cyst? Is this an abscess? And then being able to apply POCUS to that situation and get a more definitive answer, and then have that strengthen my physical exam skills. I totally agree 100%. I think that combination is, you know, it's one of the things that makes POCUS so powerful, is we're not ordering a test and sending someone off to someone. You're right there with the patient. You have your history, you have your physical exam, you have your POCUS findings, and you can integrate all of those together to make the most intelligent, informed decision that you can for the patient. Okay, this one I'm interested in hearing from all of you guys. Is focused cardiac ultrasound something you see some, few, most, or all of your colleagues doing?
You mean currently?
Currently.
For us all, I'm in a very fortunate place where all of our EM faculty are credentialed in at least the life-saving applications of POCUS, including cardiac. And I think every single of our 60 attendings have had at least one case where POCUS Cardiac has saved some life that they were not anticipating. So we have a lot of buy-in here, which is great.
I think for internal medicine, it's actually not. And we're like the last group to kind of embrace this. I don't know why, but there's something about our practice. We're very skittish that way, but it's exciting now because I think we're on the wave that ER was in the 90s, with people adopting it. It's now becoming a formal part of our training. I just got the position of POCUS director for our system, and we have 2 residencies, and we'll be getting formal, teaching set up for them, but it is what it is with internal medicine. So no, most of my partners don't do it. And so that's our big challenge is I see the med students now coming out with these skills. They're getting it in anatomy class and things, but one of my biggest challenges is educating my colleagues about it.
What about in the Great White North, Claire?
Yeah, I was going to say, because I actually see both environments. Although I work exclusively in ER, I do a lot of the internal medicine focused training as well. And what Gordy was saying about the sort of trainees and the med students coming in with skills that the attendings don't quite have. So we're kind of experiencing that disparity. But in my group of 80 doctors at the 2 hospitals for adult ER that I work at, and then at this pediatric center, most people are comfortable with POCUS. And as Rachel was saying, a lot of those cases that happen that are just so dramatic and so impressive that POCUS identifies, saves the day, saves a ton of time, gets to the answer. It's extremely natural that these stories get told, and then the profile of POCUS is elevated, and it just becomes something that's much more attractive. So maybe 5 or 6 years ago, it was about 30% of my colleagues were coupled with advanced POCUS applications, particularly cardiac. Now it's almost all of them, with a few of them kind of trailing along behind, picking it up. But we have a chance to teach, what our colleagues and our faculty, and that's what's been speeding it up. I think inter-faculty teaching has been very, very active up here, so it's kind of lucky.
Steve, I kind of have a preconceived notion of what you're going to say, but
yeah, just like internal medicine and family medicine, it's the frontier people like me that are starting to dabble in it, and we're a ways behind for a few reasons. We're kind of like internal medicine, kind of high touch, low technology sort of profession. So this seems procedurally maybe a little out of our lane. And I think there's also just some anxiety of, gosh, what is my local cardiologist going to think if I'm looking at hearts? Will he think that's a little outside of our lane? So we're probably going to slowly evolve as medical students and residents come online with skills, and we see specialists using it more, and maybe even getting encouraged by specialists that this is something within our skill set to start adding more. And of course, it certainly helps that the costs keep coming down. The artificial intelligence that's on the horizon to start making some interpretations easier is going to be huge at the primary care level.
So I'd be interested, I don't know if any of our cardiologists are still around, but if assuming adequate training and reasonable competency, how would any of you all feel about your primary care community doing focused cardiac ultrasound? Just by virtue of Steve's concern, related concern that some of his colleagues might be worried that cardiologists in the area would be ruffled feathers about it.
We would be happy. I mean, one of the things we struggle with, right, is triaging patients into our clinic. So who needs to be seen the next day and who can actually wait like 2 weeks to be seen. And so just kind of having a brief upfront kind of idea of what's coming in would be super helpful. I mean, we're doing it in our office in some way, right? So if someone comes in short of breath and they've just had, a cabbage, I'm saying, is their EF down or do they have an effusion? What's the issue? And so, throwing it on. But if the primary care can do that and help us with that, we'd be really supportive. Again, as director of our echo lab, I really don't think that our comprehensive on-cart echo volume will go down, because I don't know what the right term, I guess you want to say.
It's perfect. I'm smiling because you didn't say formal.
Well, but again, and I think we need to come to
Come on, Noreen, fight back, fight back.
No, because I think it's so important. Like the ASC says that a comprehensive echo should have strain. Strain is not happening on a point of care ultrasound. And so this all goes to, your end user understanding the technology and understanding what you did and did not see, right? And so again, we cannot see everything currently with POCUS. And so people need to understand which echo was actually done so that they understand if more testing is needed. And we probably as a group should come to a terminology that we all agree is.
We call it comprehensive echo.
Comprehensive echo and then POCUS.
Mm-hmm.
Okay.
I also agree. I think it would be useful in, especially if they're trained to get at least basic information. I'd rather keep my echo slots open for folks that I know are not normal, right? So, if they can do I'm trying to get patients in who need it, and I got, these people getting normal echoes. So if they can do a quick screening, I'm like, okay, EF's good. There's no tamponade. There's nothing crazy going on. We can get them their comprehensive echo 4 weeks from now, and I can save the slots open. And, with technology, they can snap a video and shoot it right to my phone, and I can take a look, get a second opinion,
And during COVID, y'all wanted our bedside echoes. So, there's that.
I knew that was coming, Rachel.
Still happening.
Mm-hmm.
What I was just going to add is that I think it's really important just to recognize the limitations of what you can do and interpret, because it's not very infrequent that we get cases that come up to the CCU with diagnosis of heart failure and severe aortic stenosis, and that those are things that you can't really get from POCUS in terms of how severe the aortic valve is stenosed. And so when you hear that, you already sort of are ready to jump back, saying, don't jump the gun. Maybe there's some stenosis. You don't know how severe it is and what's going on. We have to do gradients and do a lot of different views. So I think it's really important if other people are doing cardiac ultrasounds or whatever our term is going to be, that you understand the limitations of your own interpretation and what the device could actually do.
And that's like a perfect example, right? Because someone comes in with aortic stenosis, you hear that whopping murmur, they have chest pain, the next call is to cardiology, because we don't do these, stenosis gradient estimations. And the most we can do is run back to the computer and see what they had in their last echo, if they had one. So I think it is part of our natural training of residents to understand when to do that and when to rely on, their own bedside echo. But there's certain situations for sure. Even PE and PE severity, whether you call cardiology for their comprehensive echo or not. And there's, as we have gradients between us and critical care, there are certain advanced things that, we in the POCUS world are doing. So for instance, tamponade is a great example, right? Mm-hmm. So you can say that I visually think there's tamponade here, but it makes a little bit more difference if I say, hey, we actually have MVI respiratory phasic changes. That's going to get someone's attention a lot more than Joe Schmo saying, hey, I think we have an effusion with tamponade,
So, yeah, I just want to point out, especially because, I do comprehensive transthoracic echo primarily, that you and all the panelists here, right, are super educated at the highest end of doing POCUS and interpretation, right? So you guys understand, and we were talking about this in chats, like, the sensitivity for dissection is 20%. Like, it should never be used to rule out, right? It's great if you see it. And then the specificity for PE is terrible, right? And this is even POCUS or comprehensive echo, And so you again, I can't emphasize enough how important education is in all of this, so that people aren't like, oh, the RV looks fine, they can't possibly have a PE, or all of this stuff, because you have to understand really, really, and many of the limitations are universal to also comprehensive transthoracic echo. Those sensitivities and specificities hold up across both modalities. And so understanding it, I think, is really, really important.
And it also comes back down to very high or very low pretest probability.
Yeah.
Absolutely.
Yeah. When we break ultrasound education down, or at least I do frequently, into sort of 4 components. There's an indication, right? So recognizing what kind of patient would benefit from having an exam done. There's image acquisition, which frankly, for most learners is like 90% of the battle, is learning to get good quality images they can interpret. There's interpretation. So, which frankly, I think my 13-year-old can interpret echo pretty reasonably just from sitting over my shoulder most of the time, at least POCUS, not comprehensive. Is there a diffusion? Is there not? It's pretty easy to train someone. And then there's the often neglected fourth one, which is where we're going right now, which is integration into your clinical findings. So in the same way that, if I see if I do a focused abdominal sonography in trauma, a fast exam on a trauma patient, and they have normal vital signs, and I don't see any free fluid, that's really done nothing to me, to my post management of that patient. They may very well have a large liver laceration or a splenic lock, and POCUS isn't the right test for that. So on the other hand, if you look and there's a bunch of free fluid, you're going to prioritize the care of that patient over that, in a way that you wouldn't have otherwise if it was negative. You still need to do the other testing, but it changes things. And I think that's where things like dissection and PE and those disease processes fit in for us. If we see a dissection, we've really narrowed our pathway, but it is absolutely critical that people understand that looking with POCUS for dissection does not rule out dissection. And these are really, that clinical integration, knowing the limitations of the test, I think is as probably more important than any of the other parts. But it just tends to be the least emphasized, because I think as new learners approach ultrasound, they get really worried with, how do I get good images, or how do I interpret the image? So I 100% agree with being mindful of those limitations.
Yeah, Mike, I have to second that too. And I think as doctors and we're learning, somehow we feel this responsibility that I put the probe on a patient. I've got a couple of medical students in residence there, and I say, well, I think the EF is good, and when I really didn't get a good window. And I think we really have to be comfortable saying this is an indeterminate scan, inadequate scan. I'm about to say I need to get a formal ultrasound or echo, but I didn't. I need to get comprehensive or another scan. And I don't know if you guys have found that. I myself, early on in my training, we're not used to, I think, as doctors saying, I didn't perform. I couldn't figure out the answer to this. But I can't emphasize enough to the trainees, just know the limitations. I do indeterminate scans all the time. A big obese patient coming in, I look at the heart, I think I'm going to suck. I can't see anything or enough to make that decision.
Maybe that's one of those things alongside POCUS training is practicing saying, I don't know. That's the fifth I in your insonation image acquisition. That's the I don't know, indeterminate. Because if you practice just saying, I'm not sure, I think I can get some data with POCUS, I'm going to integrate that data. But if I don't know, I'm going to honestly, I don't know it. It's going to be indeterminate. And being really comfortable, which is hard for us because we're in the driver's seat a lot of the time, pretending to be experts. Being comfortable with uncertainty.
I think one of the things.
Oh, just a quick tag on it. First of all, definitely adding the fifth eye now, Claire. And beyond that, one of the things that you learn from getting comprehensive echoes when you have an indeterminate study is that when you've reached that inflection point on your training, guess what? The echo technologist couldn't get good windows either. Right. And it just ends up being a limit. The person has, their post-op and they have subcutaneous emphysema, or they're obese, or they're barrel chested, or whatever else it is that's making it challenging to get windows. Those windows are hard to get. And I think that is a critical point, Gordy and Claire. If you don't know what you're seeing, it's okay. Yeah. You just proceed as if you didn't do that POCUS and do the other testing that you would otherwise do to try and get to the answer.
Yeah, Mike, I want to jump in just for a second, just to really emphasize this point. Candidly, if we didn't have an hour of good stuff, I would end the webinar right now with this very point, because that's how important I think it is. Because I don't know, it's been such a barrier for people to adopt it. Training is hard, education is hard. I don't know how to use it. As a physician, I'm very uncomfortable of not knowing in front of my patient. That's a universal thing that we all feel. Your advice here, particularly as experts, saying this is a message that needs to resonate loudly from here. This is part of learning a new skill, learning new technology, and I don't know is fine. And we got lots of other techniques that can follow on afterwards. So I hope this resonates really well with our audience. It's a really important point that you guys have brought up, and clearly a key message that should come out of this evening.
I have to run and I won't be able to stand, but I want to tell one thing that we're doing to help with this problem, which is that we have managed to get all of our point of care ultrasound images into our formal echo reporting system. And so that they are all cataloged in the same place, so that if someone takes pictures and doesn't know, they can simply call our cardiologist on call. We have someone on call to respond to all point of care cardiac ultrasound questions, and they can provide a cardiologist interpretation of it if they think that they can see anything different that the person who took the pictures didn't or couldn't get. And so it really helps to close the loop to say, you know what, no, this person does need this additional testing based on these images I'm seeing. And having that backup and an easy way for everyone to be on the same, for future patients too, you know, for future encounters is critical. Because, you know, we had a case where, you know, we were told, you know, the point of care ultrasound said the EF was normal. And then 4 hours later, I did a point of care ultrasound, the CCU and the EF was 20%. And sure enough, the difference actually was that dramatic. And this person had fulminant giant cell myocarditis. And in that period of time, and that being able to compare those two and actually being able to look at them and say, nope, that's exactly what happened, shrank the differential like that. But so many times right now, because the infrastructure is not there, this is like word of mouth, that like these images, you know, and so getting this formalized with your technology department is critical, and it should be treated exactly like regular or comprehensive transthoracic echo images and stored in the same place.
It's treated the same way as an EKG, right? I mean, if
Absolutely.
I'm interpreting an EKG in the emergency department, it's a really strange rhythm and I'm having a hard time with it, I can call a cardiologist or an EP doc if they're around and have them take a look, right? I mean, it should be exactly the same for POCUS.
Yeah.